Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. Welcome back to another episode for Curious Minds in Nurse Anesthesia. It's me, Chloe Gomez, and today I am solo again, no guests. We're diving into a topic that's foundational to everything we do in the OR, pharmacokinetics, or as I like to call it, we are talking about the ABCs of ADME. In this episode, we'll unpack what the body does to drugs we give, how they're absorbed, distributed, metabolized, and excreted. We'll break down the concepts between volume of distribution, first pass metabolism, compartment models, and context-sensitive halftime. And I'll explain how all of this matters for real-world anesthesia care. So let's get into it. Hello, my favorite learners. Welcome back to another episode. Today, we are talking about pharmacokinetics. If you have not listened to my podcast with Dr. Bowman Dally, head over, listen to it. We talk about not only the fundamentals of pharmacology, but we dabble in pharmacodynamics, pharmacokinetics, and all of the things, just very surface level. So today, it's just me and you, no guests. We're going to talk about pharmacokinetics. So let's get into it. First and foremost, let's go through what pharmacokinetics even is. So the definition of pharmacokinetics is what the body does to the drug. So this is your ADME. That's what this podcast is called, the ABCs of ADME. Say that 5 times fast, but you can't. So this is the absorption, distribution, metabolism, and excretion. So why do we care? That's kind of my theme throughout all of these podcasts is why do we care? Why do we care? Why do we care? These are very lofty and theoretical things, and it's easy to get stuck into the chemistry of it all, but at the end of the day, how do we use this to keep patients safe? So as anesthesia providers, we need to know the timing of our medications, how it varies from person to person. We also need to know how to administer to get the desired effect with minimal side effects, because that is our goal. Keep our patients anesthetized and with as little pain as possible given surgery, and also with minimal side effects. So that is why we care about the concept of pharmacokinetics. So the first segment we're going to talk about, absorption. This is how we give medications, and it tells us about its bioavailability. Bioavailability, which could be, on an exam, the definition, how much of the drug, will enter systemic circulation and reach its effect site. So when we talk about this, we talk about modes of administration. So that's enteral, so oral or via the GI tract, parenteral, which is IV, subQ, IM, epidural, and intrathecal. There's also the mechanism of administering medications in terms of pulmonary and topical. So let's talk about the bioavailability of all these different routes of administration. So starting with intravenous, what is the bioavailability of intravenous medications? How much of this drug ends up in the bloodstream? Well, since we're injecting directly into the bloodstream, it is 100%. This is the most rapid onset, allows for titration of doses, and suitable for large volumes. Comparatively, intramuscular is 75 to 100%, so less than 100%, but no less than 75%. Moderate volumes are feasible, but may be painful to inject into the intramuscular site. Subcutaneous is about 75 to 100% as well. You need smaller volumes than intramuscular, still may be painful, but suitable for implantation of pellets. Medications like birth control that they used to have those pellets subcutaneously. Oral, 5% to 100%. So huge variability there. It's the most convenient and most economical. However, the first pass effect may be significant. So that first pass through the liver may decrease the amount of bioavailability. And it requires patient cooperation. Patients that are fully awake and alert enough to take oral medications, which in anesthesia is never the case. Our patients are anesthetized. That is what we do. Rectal medications are 30 to 100%, so a little bit more than oral in terms of bioavailability. It has less of a first pass effect, which makes sense because I said it has a higher bioavailability than oral medications, and useful for pediatric patients because they're not always able to take oral medications, right? And we could go into inhalational and all of the other medications, but bioavailability is essentially the amount of the drug that enters what? Systemic circulation, or the blood. We can just say the amount that enters the blood in an unchanged form after its administration. So many things will affect this, as I previously mentioned. pH, pKa, which we won't touch on today, but I'm going to do a whole lecture for my students in the classroom about pKa. So let me know in the comments if you want a special pH, pKa, lipid solubility lecture. Lipid solubility, blood flow, all of these things impact bioavailability. Also the first pass effect, like I had mentioned. First pass hepatic metabolism is where the drug is given mainly orally and rectally. Because of this first pass rate, the decreases this bioavailability, or the amount of drug that enters the bloodstream. And therefore, an increased dose of the drug is required for a clinical effect of the drug. All right, let's talk about the compartment model. So this is a way to think about a drug where the body is separated into imaginary sections or compartments. There are mathematical models that describe how a drug spreads, stays, and leaves the body. So the one compartment model is similar to injecting a drug into an IV bag. It mixes quickly and evenly. This example is lipophilic drugs. The downside is it doesn't describe how lipid-soluble drugs linger in fat or redistribute after administration. So that's the one compartment model. Two compartment model is like giving a med through a central line, and it takes a while to reach the end organ tissues. So central, highly perfused organs versus peripheral, the fat and the muscles. So the drugs move quickly to the central compartment and then redistribute into peripheral. Mostly lipid-soluble drugs do this. So for example, propofol makes the brain go to sleep, then redistributes into the fat and the muscles, and patients wake up quickly. So I kind of touched on this in other podcast episodes, but the main reason why patients wake up so quickly from propofol is not because of metabolism, it is because of redistribution. So this two compartment model has the central compartment, which is the vessel rich, and the peripheral compartment, which is the vessel poor. So I'll put a little chart right here on the YouTube channel, but the vessel rich includes what you would expect to include: heart, brains, lung, liver, kidneys, blood. The peripheral compartment includes muscle, fat, and bone. So for the central compartment, or the vessel rich, this gets 75% of cardiac output, or 10% of body mass. The peripheral compartment, comparatively, gets 25% of cardiac output, which is 90% of body mass. So again, why do we care? The vessel rich group is where drugs go first and fast. So propofol hits the brain, go to sleep. Peripheral compartment then is where drugs go second and slowly. Patients wake up quickly because that propofol has gone from the brain into the fat and muscle, and the patient can wake up. So this explains why propofol wears off so quickly: metabolism and redistribution. This impacts the dosing in obese patients because they have more adipose tissue or a larger peripheral compartment to store the drug. It's also used to calculate volume of distribution. So volume of distribution, the definition, describes the spread of a drug after it's given. So it's a theoretical volume that would be necessary to contain the total amount of the administered drug at the same concentration observed in the plasma. Dang, that is a mouthful. So what am I talking about here? Volume of distribution equals the equation: dose of the drug divided by the plasma concentration of the drug. So, for example, and I'm going to do a little science experiment in my class with my students, but a large volume of distribution is like drops of dye into a pool. You need a larger dose for effective plasma concentration because that pool is so big, as opposed to drops of dye into a teacup. You put the same amount of drops of dye into a teacup, there's a smaller dose is required for effective plasma concentration. So that is volume of distribution. I hope that analogy with the pool versus the teacup is a little bit helpful for you. So in terms of distribution, we have to talk about the plasma concentration curve. So what happens to that IV drug when we push it? Well, the concentration in the blood wanes over time, and this curve helps us understand that. So let's look at it. The plasma concentration curve shows that the amount of drug in the blood is the highest directly after administration, and then it declines into two phases: the distribution phase and the elimination phase. The distribution phase, when we push an IV drug, The drug floods into the bloodstream or the central compartment and then starts to spread to other tissues like the fat, muscles, organs, or to the peripheral or vessel pore compartment. So drugs that are highly lipid soluble leave the bloodstream quickly because they can cross cell membranes easily and distribute widely. However, the elimination phase of this curve is the beta phase. After the drug has reached its equilibrium between both the tissues and the bloodstream, the body metabolizes and excretes the drug, causing the curve to slowly decline as the liver metabolizes and the kidney excretes the drug, for example. So, again, why do we care? The elimination phase is where the drug's half-life comes from. So it's the time it takes for the plasma concentration to decrease by 50%. This tells us how often to redose and how the drugs may accumulate. So essentially, to sum up this plasma concentration curve, the x-axis is the time after administration. The y-axis is the amount of drug in the bloodstream. So it starts at 100% concentration when we administer it IV. It kind of rapidly goes down because we've administered it, and especially lipid-soluble drugs become redistributed. And then the elimination phase is when the liver and the kidneys start to metabolize and excrete, and it goes slowly down to 0% of plasma, or milligrams per liter in this chart. It slowly goes down to 0 as the drug is being metabolized and excreted. And again, why do we care about this curve? Because this curve tells us the drug's half-life, which is a very important concept. So next, let's talk about, we talked about distribution, we talked about absorption. Let's talk about metabolism. This is converting the drugs that we give. It is not breaking them down, as Dr. Bowman-Dally said. It's a buzzword in her classroom. It is also one in mine. This is also called biotransformation. It's the chemical process that changes drugs into forms that the body can eliminate. We must turn lipid-soluble drugs into water-soluble drugs so that the kidney can excrete them in the urine. So an important concept in metabolism is first order versus zero order kinetics. Sounds boring, but let's get into it. I'll break it down for you. First order kinetics, which is most drugs, is where a constant percentage of the drug is cleared over time. The more drug there is in the plasma, the more it gets eliminated. So that makes sense, right? There's a constant percentage of the drug that's being cleared over time, aka first order kinetics. Zero order kinetics. Zero is rare. An example of this is alcohol. A constant amount is cleared no matter how high the drug level is. So the system or the enzymes are saturated. System saturated, it cannot go any faster. That's zero order kinetics. So where does metabolism occur? Mainly in the liver. Okay, so if you guess liver on how is this drug metabolized, you'd probably be right. But other drugs are also, especially in anesthesia, metabolized in the plasma, lungs, GI tract, kidneys, brain, and skin. So how does it happen? How does metabolism happen? Well, there's phase 1 and phase 2 elimination, or metabolism rather, in the liver. So phase 1, we're going to talk about it in terms of modifying the drug. Phase 2, we're going to tag and eliminate the drug. So phase 1 is like cutting up the trash. Phase 2 is like putting it in a labeled bag so the kidneys know how to throw it out. Okay, so phase 1 reaction, again, to modify the drug. So the goal is to make the drug more polar or water soluble. So the liver can do this in 3 ways. Oxidation, you can add oxygen, and it will use this cytochrome P450 enzyme system to do this. Reduction is another way that the liver does this, and that's by adding an electron or electrons. When the oxygen is limited, we go through reduction metabolism. And lastly, hydrolysis, adding water to split the drug into separate parts. So for example, lidocaine undergoes oxidation. Ester drugs like acetylcholine are hydrolyzed in the plasma. So it just depends on the medication in terms of how it is metabolized. So let's talk about the cytochrome P450 system within the liver. The group of enzymes, this is the group of enzymes that perform phase 1 oxidation or reduction reactions by adding a functional group like NH2 or COOH to prepare them for phase 2. So again, why do we care? This is like a crazy concept. Well, each patient has a genetically different CYP system, enzyme system, which can affect how fast or slow the drug is metabolized, the efficacy, and also the toxicity. So it's super important to understand these concepts because patients can have variations of these enzyme systems. So let's talk about the 2 different types of people. So we have people that are fast metabolizers or have enzyme induction. So some drugs stimulate the liver to produce more enzymes, increasing metabolism. Common inducers are alcohol, phenytoin, phenobarbital, rifampin, and carbamazine. They have lower plasma levels and require more frequent dosing because there's an enzyme induction. However, there's also enzyme inhibition or slow metabolism. Some drugs block enzymes, slowing metabolism. So common inhibitors are erythromycin or cimetidine. You have a higher risk of side effects and toxicity, and they require lower doses because of that. So enzyme induction, I think of it like this. Alcohol blocks all of those things. Phase 2, let's go into phase 2. So phase 1 is done. We've modified the drug. Okay, perfect. We've made the drug more water soluble. The next step is to go through phase 2, synthetic reactions. So tag and eliminate the drug. The goal is to synthesize a new form of the drug that's easier to excrete by the kidney. So how do we achieve this goal? Well, conjugation, by adding a water-loving or hydrophilic chemical group to the drug or its metabolite. This occurs in the smooth endoplasmic reticulum of the liver, in the microsomal enzyme system. These enzymes are also found in the GI tract, lungs, kidney, and skin. So that is how we get these drugs ready for our last topic, which is elimination. So this is getting rid of the drugs we give. So let's talk about the definition of elimination half-life. How long does it take for a drug in the plasma to decrease by 50%? So anything slows the metabolism or clearance of a drug may increase its half-life. So decrease renal clearance, decrease liver metabolism, all of those things would slow the metabolism or clearance of a drug. Something that I want you to remember is that it takes about 4 half-lives for a drug to be eliminated from the body. So the rule of thumb is that you multiply the drug's half-life by 4, and that's how long it would take for the drug to be gone. So kind of remember that. Let's talk about context-sensitive half-time. So this is how long it takes for a drug concentration to decrease by 50% after the infusionist stops. But it depends how long it was running. So that's the context-sensitive half-time part, that context. So we in anesthesia don't just give one drug one time. We're usually giving multiple doses or infusion, and that's where context-sensitive half-time comes in. So I want you to think of a wet sponge. This is whenever I talk about context-sensitive half-time, I use this analogy. I want you to think of a wet sponge. So the water inside of the sponge is the drug concentration in the blood. The stream of water from the faucet is the infusion. The longer the faucet is on over the sponge, the wetter it gets and the longer it takes to dry. So that is an example of context-sensitive half-time in terms of having an infusion. It sticks around. So if you think of that drug medication, we won't talk about it in terms of the vessel-rich or vessel-poor group, but that has a lot to do with context-sensitive half-time. If you have questions about that, drop them in the comments. But just super simply, if you have that sponge with the water faucet running through it, you turn that faucet off. It depends how long that faucet was on, how absorbed or how wet your sponge is going to be, right? So that context-sensitive half-time is dependent on how long you were running, let's say, a propofol drip. That's when it comes into play in anesthesia in a big way. A couple more terms that we can talk about when we talk about elimination is front-end kinetics. So this is how fast the drug hits the effect site after injection. Back-end kinetics is how the drug levels fall after stopping the infusion. And the decrement time is a general term for any percent drop, not just 50%. So these terms may be asked to you in the clinical setting for someone who wants to, quote, pimp you on this. Great terms to know and concepts to understand. So again, why do we care? It helps us predict wake-up times for patients under general anesthesia, especially with a propofol drip. Can avoid drug accumulation during cases, and aids in correct selection of drugs for long cases. So for example, a propofol drip. If you're doing a long case under general anesthesia, you can technically back off of the propofol in a timely manner to make sure that the patient wakes up appropriately. So the timing of our propofol drips make a huge difference, and understanding all of these concepts, including context-sensitive half-time, is super important clinically. Even if some of our listeners have been practicing forever and haven't really thought of the term context-sensitive half-time, you technically think about it anytime you use a propofol drip and turn it off in a timely manner so the patient wakes up. So let's talk about clearance, how quickly the drug can be eliminated from the plasma. This is the volume of the plasma completely cleared of a drug per unit of time. So this impacts how long the drug is active, how often to redose, and its steady state. So it's like a filter. If running a dialysis machine, clearance is the amount of plasma from which the drug is completely removed each minute. This is influenced by the drug's properties, whether lipid soluble or water soluble. So organ function makes a difference. So liver, kidneys, blood flow to clearing organ. If you don't have a lot of blood flow to your kidney or liver, that could impact its clearance, and enzyme activity within the liver, those CYP450 enzymes in particular. So let's do a quick summary of hepatic metabolism and renal clearance. Hepatic metabolism is perfusion dependent on liver blood flow. For example, if you have hypotension, you may have a slower metabolism. It is also enzyme dependent. So those cytochrome P450 activity is really important to know. For example, the enzyme induction means you have a faster metabolism, and enzyme inhibition means you will have a slower metabolism in the liver. Second, let's do a quick review of renal clearance. We eliminate water-soluble drugs through glomerular filtration, tubular secretion, and some absorption. These are the requirements of a drug to renally excrete. Must be water-soluble, must be unbound in plasma. The pH of the urine affects drug excretion. Weak acids are excreted better in an alkaline urine and vice versa. So weak bases are excreted better in acidic urine. Lastly, we're going to talk about some patient factors that will influence pharmacokinetics. As always, age impacts pharmacokinetics. Elderly patients have decreased renal function, decreased liver function, increased body fat, and also not just elderly, but neonates have an immature or renal liver function. So that is what we consider when dosing our medications based on the pharmacokinetics of those patients. Next is gender. Muscle relaxant sensitivity in women, propofol sensitivity in men. We have a higher emergence and higher recall risk in women. Opioid side effects and dosing differences differs by gender. Women sensitive. Next is temperature. So a lower temperature, you're going to have a slower drug metabolism. You're going to have with the decreased temp, you will also have a prolonged recovery because of that. However, the opposite, an increased temp is a faster metabolism and faster recovery, and an increased temp has a potential for overdosing. Disease states, chronic kidney disease, you have decreased renal clearance and increased drug or metabolite levels. Liver disease, decreased metabolism, altered volume of distribution, decreased protein binding, altered distribution and clearance. So these are all of the things, the factors that patients may have or be predisposed to having variations in pharmacokinetics. So super important concept to understand and know. That's a little bit about the ADME, or the pharmacokinetics of what the body does to drugs once we administer them. So if you have any questions or comments, let me know, put them in the comments, whatever you want to do. It was just a pleasure being with you today. Okay, I'm going to end this podcast like I do every time with a word of encouragement. My favorite thing to say most recently to myself and to others is you can't be good at things you never do. So if you're doing something for the first time and you're getting really frustrated because you're not good at it yet, you just haven't done it enough. Continue to push through, continue to practice, continue to try, and that is all you can do. Show up with a positive attitude and try your best, and don't give up. Little cliche there at the end, but just remember this: I can't be good at things I never do. So that is my word of encouragement. Until next time, my favorite learners, bye. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.